Yeah, good morning. You hear well? The microphone works. We did not coordinate the two talks, but there were, of course, things that Peter said that I will repeat. So I'll do it briefly, and we'll go to things that were not mentioned. I do agree that the luteal phase is relatively neglected by us and by the pharma industry because progesterone and estradiol are cheap stuff. You cannot put patents on them, but you can on gonadotropins, antagonists, agonists, etc. A lot of attention, as Peter said, is spent on late follicular progesterone. If it goes a little bit more, a little bit less, what is the repercussions, etc. However, nobody really talks about the luteal phase, and it's a shame because we have a challenge to maximize endometrial receptivity, and we are not there yet. There is still a way to work and to go. What I will speak about, physiology, Hcg is trigger, when to stop luteal phase support, GnRH agonist as a trigger. I'll speak about luteal coasting, and to remind everybody that timing is everything, especially in our profession in reproductive endocrinology. So this is the actual data from one of the papers that looked at the physiology of the luteal progesterone secretion pattern. And you see down here, a few points should be mentioned and emphasized. First, during the early luteal phase, the progesterone rises continuously. There is no drop. It rises continuously to somewhat plateau in the mid-luteal phase where everything happens. Everything is implantation. If the embryo is implanted, Hcg will be secreted, corpus luteum will continue to produce what it needs to produce, and we have pregnancy. If not, progesterone will decrease, corpus luteum will die, and we have menses. We can deceive the system by putting more progesterone here in the luteal phase. Patient will not bleed, but this is the deception. Nothing will happen. Of course, Hcg Is Trigger is the default gold standard trigger agent that we all use on a daily basis, and there is a question of dose to mimic the LH surge in amplitude, and Peter mentioned 130. This is what we get for the LH surge. This is what we need to get from the Hcg when we use it as a trigger. And it works fine for most patients. It usually follows with vaginal progesterone for luteal support. This is what we do. We saw that before. So remember, the Hcg level should be more or less what we have for the LH to secure full mature oocytes. And then we have a slow decreasing that takes days of Hcg, which we don't have, of course, in the natural surge. So we have all this area of blue line in the Hcg that we don't have in physiology in the natural luteal phase, which is all but redundant. We don't need that. There is a price to pay for that. And what are the problems with the Hcg Is Trigger? Of course, we deviate from physiology. We don't have FSH surge. Most patients don't need that, but not everybody. We have the problem of long half-life that extends way into the luteal phase. We have early luteal overstimulation of the system, which might bring you for some asynchrony in the receptivity of the endometrium. And we have the most important problem. We have the peak progesterone that does not coincide with the implantation period, and Peter spoke about it. I'll bring more data to show you. And the question remains whether we reach the maximum endometrial receptivity under this protocol that we all use on a daily basis. A few words about the FS surge that we all forget and don't have with the Hcg. It does promote, as Peter said, LH receptor formation in the luteinizing granulosa cells. It promotes nuclear maturation, promotes cumulus expansion, and more. There is a lot of material in the literature, and I will not go into this, but it will be, probably it is not totally redundant. Now, what is the price that we have to pay with the Hcg Is Trigger? We spoke about the supraphysiologic stimulation of the corpus luteal in the early luteal phase. and the supraphysiological level of the estradiol and progesterone, and early hyperstimulation that we get, the negative feedback at the pituitary, low endogenous LH secretion, and we have this LH hole, or the luteal phase defect. So we need the luteal phase supplementation, and we have the abnormal progesterone production that does not coincide with the implantation, and maybe we have the outer phase endometrium giving the very high early progesterone that we don't have in physiology. Now, this is what happens after you give the trigger with the Hcg. So it reaches the peak of 120, 30, whatever, and then it slowly goes down. And then if the embryo implants, it will produce from the placenta the Hcg. Now, there is a dark or gray area actually here that we don't know really what happens. So if the Hcg decreases, however, the embryo implants before it's totally eliminated from the system, good for us, good for the embryo, because the Hcg will overlap, produced from the embryo, will overlap the Hcg given from as the medicine, and corpus luteum will continue to go on, and we'll have a successful implantation and successful pregnancy. By the way, this is from Filicori paper that was mentioned earlier, and we see unlike what we have with the Hcg that goes down like this smoothly, we have the pulses of LH in the early luteal phase that totally do not look like what we have with the recombinant Hcg. Of course, in the luteal phase, we have special needs for progesterone, not for Hcg. And we cannot predict the pattern of Hcg decay, so we give progesterone for support. Because, as Peter said, every patient behaves differently. So everybody is covered with progesterone. This is, I think, the most important maybe message in my talk. And this is the correlation between mid-luteal progesterone in nanomole and earlier pregnancy loss. So if we go very high with the progesterone in the mid-luteal phase, more than 400 nanomole per ml, you get only 10% early pregnancy loss, which probably reflects what we have with genetics, aneuploidity, and embryos that will never survive anyhow. But if we go down to less than 50, this is what we get from the luteal phase support that we give. The implantation, the early pregnancy loss goes up to 80%. So this gap is enormous. From 10% to 80%, all these 70% losses can be avoided if we keep the progesterone high towards the 400. So there's a lot of work to be done when we assess a patient with repeated implantation failure. Maybe the solution or the secret is here. Progesterone is not enough. If we push the progesterone higher, and we'll see how to do that, we can save the cycle, and we can assure a good implantation and ongoing pregnancy. So we need more than 400 nanomole of progesterone in the mid-luteal phase, but the progesterone-based luteal support that we give cannot reach a plasma level of 400 and plus nanomole per liter, not mentioning the other vascular mediators and interleukins that we get from the corpus luteum that we don't have, of course, with the support that we give. And endogenous progesterone production is not predictable because we don't know when the Hcg will stop working in a given patient. So we do call it control of iron stimulation. But there's a big question mark. Do we really have control in the luteal phase? We delude ourselves. We may have control in the follicular phase. We don't in the luteal phase. So this is the big elephant in the room. So we talk about endometrium, endocrinology, Utugichal, but the question is whether all these guys will help to solve the big mystery of the luteal phase. This is the big elephant in the room. But we keep looking at the literature, and we see extensive research that misses the point. For example, this is in press in RBM Online, and we see a lot of effort being invested in studies to compare Progesterone and Crinon, and Crinon of this and Crinon of that. This is not the point. All these guys are pretty much the same, but they don't deliver. What about the luteal progesterone post-ovarian stimulation? We know that the luteal phase in the natural cycle is around 30 nanomole per liter. However, following ovarian stimulation, the need for progesterone is 3 or more times higher, according to Jovic, that was mentioned before, and other publications. Why? Good question. But it also comes from previous studies that looked at problematic patients with high follicular response but low pregnancy later on from about 20 years ago. Clinical evidence for a detrimental effect of uterine receptivity of high serum estradiol concentration in high and normal responder patients, or lower implantation rates in high responders, evidence for an altered endocrine milieu during pre-implantation period. Is it secondary to insufficient progesterone during implantation window? Probably yes, because the higher you push the estradiol during the follicular or the late follicular phase, probably the higher progesterone you need. So a patient with, say, 10,000 picomole per liter late follicular phase estradiol will be 10 times more than she gets on a regular menstrual period or cycle, which was about 1,000. So if she would do fine with 30 nanomole per liter in the luteal phase, she might need 300 now in the luteal phase, because the estradiol level exposure during the follicular phase was 10 times higher. So what do we know about the endocrinology of the luteal phase post Hcg trigger in IVF? Peter mentioned a few papers. I will repeat other papers, and we'll see, for example, from this study, the peak progesterone, this is the control group, will be 3 days after oocyte pickup. Again, we need the peak progesterone when implantation, 7-8 days after pickup, not so early. Again, from Becker's and other study, we see that the peak occurs 7 days after the trigger, again, 5 days after pickup, again, a day or 2 or 3 earlier than what we have in physiology, too early. Another study that was published, we see the decrease, first the going up with the progesterone after the oocyte pickup, and the mean day of 6 days after pickup, and then during the implantation period, which is the important one, we have a decreasing progesterone, not increasing progesterone. And the levels are 60 nanogram per liter. And again, we want much more than that to decrease miscarriage rate later on. So Hcg doesn't deliver. It doesn't work well for us. We don't need this decrease. If we want to mimic physiology, remember what I told you? In physiology, it increases all the way up to a plateau in the mid-luteal phase where implantation should occur. So this decrease is not good for us. This is another, more data from another paper that I was asked to review. Again, you see the decreasing level in progesterone during the early luteal phase. That misses the point, because during the implantation, you have lower progesterone than what we need. Here, in this case, for those who became pregnant, so the mean progesterone during the implantation period was 25 or so. This is nanogram per ml. Again, far, far from what we need to minimize miscarriage, according to previous paper published by Peter. So, to conclude, and pharma will excuse me for saying that, the luteal phase endocrinology post-Hcg trigger is a complete skew from physiology, and the progesterone products that we all use do not correct that fact. This is the icing on the cake, but the cake itself is what is important, not what's on top of it. And this is like a pacifier for us, a pacifier for the patient, but not for the embryo. When to stop luteal phase support? So in Scandinavia, they agreed to stop on the day of Hcg measurement, 14 days after retrieval. But this is a survey of more than 400 centers, and you see what people do. So 44% will say until the 10 weeks gestation, 28 will say 12 or more, et cetera, et cetera. So in over 70% of cycles, luteal phase support is giving beyond week 8, which is the luteal placental shift that we know from physiology, and I ask the question, why? Maybe for luck. It's not bad. If it's not useful, it will not cause any harm, because everybody does that, and Dr. Google says that this is what needs to be done, and the patient reads Dr. Google, as we all know, and maybe to support psychological reasons, not physiological reasons for the embryo, but for the patient. Again, like a pacifier. What happens 14 days after oocyte retrieval? If we don't agree with the Scandinavians who stop everybody, can we individually assess corpus luteum production, endocrine function, and by that decide when to stop luteal phase support? I would say yes, try to convince you. This is the paper that we published from Rambam. We took retrospectively 171 cycles with positive Hcg, and luteal phase support was stopped if on the day of Hcg measurement, estradiol level was more than 1,000 picomole per liter, and progesterone level was more than 110 nanomole per liter. Again, looking at Jovitz's papers that say more than 90 will suffice, so we go even beyond that for better. The results probably is the same, and you see that the estradiol level, which we were not supported from, but maybe medically, was way up, was way higher on the cessation of luteal phase support group than on the continuous of luteal phase patients. And the reproductive outcome was the same. So again, why continue? The patients don't like it. Why continue? Give them so many weeks of leaky, messy products that serves no purpose. So this is one message. Switching to the agonist trigger in the luteal phase. The secret of the GnRH agonist trigger is very simple. It's the quick and irreversible luteolysis that happens after agonist trigger, which can serve the OHSS-free clinic that we all strive for, but also leaves us with the option to manipulate the luteal phase to our needs. And this is, I think, where we need to focus, and not on the follicular phase, but on the luteal phase, as was mentioned before. So what's the timing here? This is a paper from Fertility and Sterility a few years ago, where 4 oocyte donors were followed. Each underwent 4 consecutive cycles, oocyte donors, same protocol. With Hcg trigger 10,000 and luteal phase support with 600 milligram vaginal progesterone and 4 milligram oral estradiol. And then agonist trigger with 1,500 Hcg 35 hours later after pickup, or the day of pickup, and luteal phase support. Agonist trigger and luteal phase support, and agonist trigger without luteal phase support. So, make a long story short, day 5 after oocyte pickup, without anything, nothing. No progesterone, no estradiol, nothing. This is mean estradiol, this is mean progesterone, complete luteolysis. Great for us. Why? We can control what's going on. Now, what is the exact mechanism of luteolysis post-agonist trigger? Not thoroughly know, although we use it for many years. So the hypothesis was that in addition to low LH during the luteal phase after agonist trigger, we might have a loss of LH pulsatility. So we studied 10 IVF hyperresponder patients who received GnRH agonist as trigger with no further support. And we took repeated blood sampling every 20 minutes, 5 patients on the day of oocyte retrieval, immediately after the oocyte retrieval, and 5 patients 48 hours later on embryo transfer day. And again, nobody got anything as support until this repeated sampling was done. It was published a year ago. Going back to the Filicori natural cycle LH, on the early luteal phase, this is day +2 after ovulation, and you see what happens. You see the pulses. You see the baseline around 10, and you see the pulses that will go up to 30. This is physiology. This is what we get. On the day of oocyte retrieval, these are the 5 patients. So LH is not completely 0, but can go up to normal. Remember, the baseline in Filicori's study was 10. Some patients will have 10. However, there is no pulses, not at all. This is physiology. This is what we get on the day of oocyte retrieval. 2 days later, on the day of embryo transfer, this is what we get. Again, LH is low, but each patient behaves differently. Some very low, some will sustain some LH activity, but then again, there is no pulses. This is what we need to see. This is what we get. So while in the natural cycle, the mean LH is 21.5, post-agonist trigger is 0.6 only. Pulse number in the mathematical calculations will be 2 to 3 versus 1.2 post-agonist trigger, and the pulse amplitude is nothing, while in the natural cycle is 12.3, according to Filicori. After agonist trigger is 0.44, nothing. So what happens in the very early luteal phase after agonist trigger? Well, the plasma progesterone level on the day of oocyte retrieval shows a slow increase, pretty much the same what we get in physiology. However, 2 days later, while the plasma progesterone reaches the peak, which is 50, it starts to decline. By the end of the day, the repeated sampling, it was around 35. And remember, this is something that we don't want to see, because we don't want to see decreasing progesterone during this time of the luteal phase. We want continuous rise in the early luteal phase. Probably this is the time to intervene if we want to correct, if we want to control the luteal phase. To conclude this small study, although pulsatile LH secretion continues, mean LH concentrations and LH pulse amplitude are significantly lower than those described for the natural cycle. And we see here a proof that the process of luteolysis starts 2 days after oocyte retrieval, 48 hours later. Now, how to rescue the corpus luteum? So Peter's protocol was to give 1 shot of Hcg, 1500 units, at oocyte pickup, and then continue with standard luteal phase support until day of Hcg, and then stop if it's positive. The mid-luteal phase, as Peter showed, after 1500 units on the day of oocyte pickup, is 74 nanomole per liter. This is too low. We strive for more than 300. This is way too low. We need to go much higher than that. You see, post-Hcg, it's around what we need, 238 progesterone on the mid-luteal phase. This is from a recently published paper. Also, Peter was involved in this paper. And we see here, I want to draw your attention to 3 patients at median mid-luteal progesterone below 60 nanomole per liter. Number 7 and number 8 were triggered with the GnRH agonist and received luteal phase support with 1500 units of Hcg on the day of pickup, and vaginal trinone twice because it's 180. However, despite having 19 and 17 follicles, more than 14 millimeters, surely hyperresponders, and 11 to 13 mature oocyte retrieved on the day of oocyte pickup, they presented with mid-luteal progesterone of only 55 and 36 nanomole per liter. Of course, they didn't conceive. So 55 and 36 nanomole per liter is what we get for 2 quinones a day. meaning they didn't have any endogenous progesterone production.
And they were treated with HCG.
No, with agonist. One of them? Okay. So again, the problem of too low progesterone in the mid-luteal phase, endometrial receptivity is not there. You'll not get a successful implantation. Papa Nicola, our friend, also studied the case, and he gave 6 doses of 300 IU recombinant LH, given on alternate days, and standard luteal support from the day of oocyte pickup, and saw nice results, although LH is, of course, problematic. It's not cheap. And there are no data on the mid-luteal progesterone. This paper was mentioned by Peter, and we see the daily Hcg 125 units until pregnancy test, which secured good pregnancy outcome. Although I might ask, what's the reason to give it in the second half of the luteal phase? Probably it's not needed. Because if implantation occurs and Hcg is produced by the placenta, why you need to support it more from injections? Bar Chava, he published a paper not long ago doing the same, but with repeated GnRH, nasal GnRH agonist 3 times a day, again from the day of oocyte pickup until the day of pregnancy test. Again, excellent results. Works fine. But then again, question rises, why to give it in the late luteal phase? Maybe it's not needed. Also, pay attention that in all suggested strategies, there is no control on the number of corporal luteal that we rescue. We don't control that. We have no control on that. So there is the OHSS risk exposure here, beyond our control. And this is very important to understand and to remember. So if you are in doubt, better freeze all. Don't take your chances. A few words about the idea of coasting. As you know, follicular coasting is a popular OHSS prevention strategy done during the follicular phase, as I said, in OHSS high-risk situation. And the idea is to stop gonadotropins and follow estradiol level daily and trigger with Hcg when estradiol drops below a certain given cutoff level, where the mechanism will be partial follicular demise, so you have less follicles, you have less corporal lutea, you have less OHSS. Trying to imitate or to take this idea into the luteal phase, the suggested strategy would be to follow the progesterone level, and when drops below a certain cutoff level, add 1,500 units of Hcg, question mark, whether you can use another dose. And the mechanism will be patient-specific partial rescue of the corporal lutea, so diminish the exposure of the risk for OHSS, and also maybe you don't need any additional progesterone or estradiol in these cases. So this is what we did. We follow a progesterone level daily from day +2, and we administered Hcg when progesterone dropped. And these are the patients that we saw. Again, interesting, you see that in most patients, the progesterone starts to decrease on day 2 after retrieval. Some will continue with high level of progesterone even without any support. And these are the patients probably that will rescue the corpus, the corporal luteal without any further support, and might do OHSS after GnRH agonist, and a few cases were reported, as we all know. And again, you see on the day 2, the mean progesterone was 63, and it dropped to 38 a day later. This is the estradiol that lags behind, by the way. Estradiol lags behind with decreasing levels, and LH was not 0. LH was there. Mid-luteal progesterone after recovery with the one bolus of Hcg was 140. securing adequate progesterone during the implantation window. Ongoing pregnancy, day plus 14 was progesterone more than 190, nanomole in all cases. But there is a question with this strategy, and this is the effect of decreasing progesterone level during the early luteal phase. We don't know what it does, how it affects implantation, and how it affects the endometrium because it's a skew from physiology, as I said. So far, Hcg was based on fixed time points in the luteal phase. So in America, they suggested give 1,000 units with trigger, meaning the dual trigger, plus estradiol and progesterone. Peter suggested the 1,500 unit on oocyte pickup plus estradiol and progesterone. In Sheba, they suggested to give the 1,500 day 3 after oocyte pickup plus estradiol and progesterone. Question is, what is the best timing? Can we fine-tune the timing? Second question, do we really need exogenous estradiol and progesterone support, or can we avoid it? If we rescue enough corporal lutea, why do we continue with progesterone supplementation and estradiol? As I said, timing is everything, and the idea, again, is to give the rescue dose just before luteolysis begins. And as I said before, luteolysis begins 48 hours after oocyte pickup. Then the idea came, why not give day 2 post-retrieval, not day of retrieval, but 48 hours later, one shot of 1,500 units of Hcg, and this is it. Don't give any more progesterone or estradiol, and let this rescue bolus do the work. Make sure that we have very high mid-luteal progesterone levels, as we want. And if the embryo implants, we give it the best chances to do so. The endometrial receptivity is the highest. And if it does, it will produce its own Hcg, so we don't need any further support. Corporal lutea will continue to secrete what is needed. That's what we did in Rambam. We looked at 44 pregnancies retrospectively with GnRH trigger, followed by day 2 Hcg, 1,500 units only. And we compared this group to data from 44 cycles where we triggered with what we all do, Hcg, followed by progesterone luteal support as a control group. And since the control group was supplemented with progesterone, it's hard to compare the progesterone between the two groups. But then again, you see in the study group that did not get anything but the 1,500 units of Hcg, mean progesterone was around 200 versus 173, which is not significant. However, look at the estradiol. It was twice as much in the study group compared to the control group, meaning we do have a proof for complete rescue of the corporal lutea this way, and pregnancy outcome was the same. So to summarize, and that's what I do now on a routine basis. If I decide to trigger with Hcg and do fresh transfer, one bolus of 1,500 units of Hcg given 48 hours after oocyte retrieval, it will adequately rescue the corporal lutea without any need for additional support. As I said before, if you are any OHSS risk, so freeze all. So to summarize, what are the rules to maximize endometrial receptivity following physiology? This is the profile that we need to follow. We need to make sure that maximal progesterone will coincide with the implantation window. We need maximal progesterone in relation to maximal follicular estradiol. This is very important. And if we say that we cannot match, so freeze all. Don't risk it. Now, if pregnancy is achieved, as I said, endogenous Hcg will take over, no need to support any further. So what happens in the mid-luteal phase is the fate of this cycle. If embryo implants, good for us, it will take over and will take care of itself. So in a cartoon, this is what we do. Antagonist cycle, GnRH agonist, oocyte pickup, 48 hours later, one shot of 1,500 units of Hcg, and then nothing. What's the benefits and limitation? It's patient-friendly, of course. It's cheap, simple, short. No need for vaginal progesterone for a long time. It's effective because the progesterone peak will coincide with the implantation window. Again, remember that progesterone levels will peak 5 days after the Hcg shot. This is what we learned from Hcg trigger. 5 days later, you have the maximal progesterone production. We don't have early luteal overstimulation with progesterone, mentioning a shift in endometrial receptivity. Limitation, of course, so far there is no RCT to support this notion. So to summarize, before we go to a coffee break, so post-Hcg trigger, consider Hcg-based luteal phase support if there is no risk for OHSS, and we'll discuss this further later on. Post-GnRH agonist trigger luteal phase support, if high OHSS risks, freeze all, don't risk it. If you go for fresh transfer, then a single bolus of 1,500 units of Hcg, 48 hours post-oocyte pickup, will do the work. Nothing else should be added. Okay, thank you.